Hello, welcome all. Coming on to the next session of the Retrograde CTO Academy. So, in this session, I would be discussing a very important technique that is reverse CART, reverse control, integrated and retrograde tagging. In this particular technique of CTO, the ballooning is done over the integrated wire, creating the subintimal space, and the retrograde wire is negotiated from the retrograde gear. So this is a very important step, and nowadays one of the most commonly done technique to get the success in the retrograde PCI. So this is the particular technique that is shown in the figure D. In this, if suppose you have a LED CTO and you are trying to negotiate the retrograde wire and it is not crossing from lumen to lumen, then we can take this balloon over this integrated wire, and once this goes balloon into the subintimal space, then we can dilate this balloon, and once this distal end is visible, and then we can negotiate the distal tip of the retrograde wire and facing towards this balloon, and as soon as we deflate this balloon in the subintimal space, then we can try to advance this retrograde wire into the subintimal space and then into lumen. And over this, we can then push the microcatheter after anchoring this wire into the integrate wire. And over that, we can externalize with the RG3 or R350 wire. So this is how the diagrammatic expression of this technique. We can see this particular case is the RCA CTO, and we can take the wire over this integrate guide. And if this wire is not able to go into the distal lumen, then we can take retrograde axis. And if good intervention collateral are there, we can cross with this retrograde wire and try to negotiate the distal cap of the CTO. And if you're not successful, then of course we can take a smaller size balloon, and we can try to put this integrated wire into subintima and try to inflate this balloon. And once this balloon is inflated, we can this guide this distal wire to steer across the subintimal space while deflating this balloon over the integrated wire. And once it reaches the lumen, then we can of course try to negotiate it into the integrated guide, and we can after trapping it with the balloon, we can push the microcatheter into the integrated guide, and over that we can this exchange the with the RG3 wire and externalize the wire, and we can do the PCI. So this is what the actually reverse cart is. Nowadays, various people use even the guideline or till the lesion, and beyond that, we inflate the this balloon, and this is called as guideline or assisted cart. Nowadays, very commonly used. So coming on to the case base, this presentation, this is a 55-year-old male smoker, tobacco chewer, hypertensive case of a old honest elevation MI, ejection fraction 60%. He had a triple vessel disease, both RCL6 and LAD disease. RCA is CTO, and he has undergone a PCI to the this diseased LAD and circumflex, and we can see we have a good, very connecting epicardial collateral from the LAD. So this is how this LAD is giving a very good epicardial collateral to the mid of the RCA. So in this particular, we can see there is a RCA total occlusion in the middle segment, and but of course there is a large branch coming at the point of entry, as well as it's a very long segment. So this was tried to negotiate with this over the microcatheter. Various wires were tried, but being it a long lesion, even the XTR was not going into the channel, and having a longer segment and branch at the site, it had a more difficulty, and it was not done, unsuccessful in the first attempt. Then, considering to the longer segment branch at the proximal site, on the next sitting, as usual, retrograde axis was taken, and the patient was planned by the retrograde epicardial collateral. Then right radial axis was taken, as well as the right femoral. From the right femoral, integrate GR guide was taken, and from right radial, retrograde gear of EBU was taken. And this was the angiogram. At this side, we can see stent in the LAD and circumflex, and good distal epicardial collateral was coming onto the mid of the RCA. So first of all, Sion wire was taken over the fine cross. So important thing in this collateral that are epicardial, we have to be very cautious because they are very prone to spasm or rupture. So we took a fine cross catheter, which is a bit softer as compared to the other catheters, and Sion wire was tried to negotiate across this very tortuous epicardial collateral, and various views were taken. Uh, Allocaudal view was tried for wiring, as well as various other views were tried. But the problem was that there was a wire was not going into the this distal LED, and from distal LED it was not going to the epicardial distal RCA. So various multiple was taken. Now the wire was changed. The wire was changed to the this SUO wire, and it was tried to negotiate it in various segments, and we were able to cross into the distal RCA. And now the we switched to this cranial view, and wire was changed with the filter XTR. We thought we can go from distal lumen to the proximal lumen. So this was tried, and considering we also took this wire into the antigrade guide, and taking it as a marker, we thought that this distal wire can go into the main lumen. But after a lot of efforts, even changing with the Gaia 1 and 2, the distal cap could not be changed, could not be negotiated, or the cap could not be big because there was again a branch at the distal end of the CTOs. Again, it's a important factor in the failure of this retrograde CTO PCI, because there were branches at the proximal as well as the distal segment, and it was a very long segment. The proximal, we tried both ways. Even the antegrade wire was tried keeping the retrograde wire as a marker, but it was not coming into the lumen. Then various other wires were tried. So this is how the things were. Now, the plan was to negotiate the integrated wire into the subintimal into the branch, and then dilate this balloon in the subintimal space. And we try to negotiate the retrograde wire into that proximal segment of the integrate uh, wire. And once the balloon was deflated, the integrate this retrograde wire, we took the gladius mongo wire that has a tendency to go from the subintimal to intima. And this is shown in the pictorial presentation on the left side, that over the integrated wire, small balloon, that what we also call the contemporary reverse guard. In this, the smaller sizes balloons are taken as compared to the conventional reverse guard, where we take a larger balloon to cause dissection. So in this particular case, this dissection was done in the subintimal space, and the wire was negotiated across this CTO segment into the main lumen. And once this, after multiple negotiation, initially the wire was not going to go, but we were able to put this wire into the integrate gear. And then the wire was this over this wire, the microcatheter was negotiated by trapping it with a balloon in the integrate guide, and then the this after crossing with the Mongo wire, and then the Mongo wire went inside, the micro went inside, then we exchange it with the RG3 wire. And after that, we pre-dilated this segment from proximal to mid areas. So now the sequential dilatation was 1.510 to 2.515 balloon was done, and we could see a good vessel over here. So in this particular case, too, we found a lesion at the distal segment also. So two discs were implanted in the RCA. And we also took the safety shaft of the left system. And at the end of the procedure, this left system was also found to be safe, and there was no damage to the collateral. This is how what the end result was. It was a good TME free flow obtained. And in this particular case, this highlights the importance of the reverse card. And this was done via epicardial collateral. So many times epicardial collaterals can be difficult, but we have to be very careful in choosing the hardware. Like we have to take the soft microcatheter like fine cross and wires like Xion or Suo wires. And for retrograde wire cross into the subintima, we have now got the wires like Gladius Mongo that traverse from the subintimal space to the main lumen while we are doing the contemporary reverse cut. So thank you all for this listening this session, and I would be coming with the next session. Thank you.